Peace be upon you and God's mercy and blessings. I am Dr. Hamdy and you are watching Simple Neonatology channel. We're going to talk about one of the most important topics. No, actually, it's not just one of the most important topics. Let me clarify. We previously said it's the most important topic in neonatology and pediatrics, but today's topic is actually the most important in neonatology, pediatrics, medicine, and surgery. Can you imagine how important it is? Can you imagine that there is a single topic that's crucial in every specialty of medicine and surgery? Imagine if someone asked you to read and learn just one topic in all of medicine and surgery, you would choose this one. Welcome everyone. Shock is the most important topic in pediatric neonatology, internal medicine, and surgery. If you ask any doctor, what is the most important topic that you absolutely must know? What is the crucial topic that is guaranteed to come up in your exams, in questions, whether oral or otherwise? The first thing you need to know is shock, because simply it can happen during a procedure or an operation. And suddenly this shock can occur for many reasons. It could be hemorrhagic shock during anesthesia. If you ask, there will be shock because any disease can occur during anesthesia and cause anaphylactic shock, of course. Not to mention obstetric patients because they are constantly living in a state of shock. And in the NICU or PICU, I do not want to exaggerate, but you will find that 20 or 30% of the cases require you to deal with shock. So shock is a very important topic that we need to address. We will approach it in our own way, using the simple neonatology method, a method based on understanding. We don't want any prior experience in dealing with it. We want to understand it. We will discuss shock in a way that focuses on comprehension. We don't think there are too many areas to grasp, but let's put it this way. How do we understand neonatal shock? We know that any medical condition we deal with should have a clear framework in your mind. And keep in mind that this topic has a report, an etiology, a pathophysiology, and then there are specific classifications, updates in diagnosis, and specializations that you should be able to imagine and handle according to their context, so you don't get lost at any point. You need to understand it first. Do you want to see this picture? This is a picture of the cardiovascular system, and this is one of the systems we will be dealing with, the cardiovascular system. Even though it might seem impossible to some, you will find it is actually very organized, a highly organized system that you will encounter often. Arteries, heart, and veins. The veins are called preload as they collect blood from the body. Then the heart adds it and the heart pumps it to the lungs where it gets oxygenated. Then the blood returns from the lungs and the heart pumps it again. The arteries help deliver it to the body. This is very easy. This is the cardio part, which is why it's called the cardiovascular system. It's very easy, a beautiful and organized system, and it even looks beautiful. All right, so failure in this system is equivalent to shock, meaning any failure in any part of it. If there's a problem in the pathway, which we call the vein, pump, or artery, then that means you're in shock, and that's the definition of shock. Now let's ask, why does the body need blood? The main function of the cardiovascular system is to pump blood to the tissues in the end. Why the tissues? Because they need blood to do something very simple, to carry out metabolism. You need to know that the functional unit of the body is the cell. Tissues are made up of cells, and cells perform a function depending on their location. And each type performs a specific function. It can do different things. It can secrete hormones, or it might produce something else. For example, it could even produce the hair that grows on us, or it could produce melanin for the body, for the skin, or other things. And so on. Whatever its location is, for example, in the stomach, it produces acid in the end. You have tissue, and this tissue is made up of cells, and these cells have a function. To perform this function, how do they do it? They do it through reactions, and they carry out chemical metabolism. So in the end, it's just my body requires essential nutrients, and I also need oxygen. While nutrients can wait for a little while, oxygen is an immediate and absolute necessity that cannot wait, not even for a few seconds, or at the very most a couple of minutes. After this period, the cell starts to change its metabolism. Basically, the cell performs aerobic metabolism, and this aerobic metabolism depends on oxygen. When there is no oxygen and it can't and the cardiovascular system can't supply this cell with oxygen. The metabolism will shift from aerobic to anaerobic. What is the problem? What is the issue with switching to anaerobic metabolism? The problem with anaerobic metabolism is that lactic acid will appear and lactic acid will accumulate in the plasma, and it will change the pH, causing it to drop because it will become acidic, and when the pH changes, it becomes acidic. And acidosis occurs in the plasma, and this leads to injury and changes in the cell. And then in this acidic medium, if it persists, cell dissolution, lysis occurs. That's why in shock, you find that the entire system reacts. All the organs experience a flare because this acidity is present throughout the system, and all the organs are functioning, but their function becomes compromised. And this acidity starts to cause cell death. Therefore, the entire system reacts, and the function of the cardiovascular system in a single word is called perfusion. Tissue perfusion means that the tissue receives blood and that blood contains oxygen and nutrients. Everything we've discussed falls under what is called pathophysiology and definition. We mentioned the definition of tissue perfusion, but you need to understand it so we don't just memorize it, but actually comprehend it. So the definition of tissue perfusion and then the pathophysiology we mentioned should start with the production of lactic acid. This means that the pH drops, leading to lactic acidemia, which in turn affects the organs and living beings. After that, what do you think the etiology will be, and how do you reach the diagnosis if you decide on this area? In cardiovascular cases, you'll find that everything is ruled out in the same way. The etiology is ruled out, the diagnosis is reached, and management is initiated. If you decide on it, you'll find that there are 3 locations. The first is the upcoming area, and the second is also the upcoming area. And after that, the arterial side, which is the afterload, may first be affected by shock, causing a flare in the first zone. As for the venous side, a flare can occur either due to hemorrhage, meaning hemorrhagic shock, or there could be a problem with intake or fluid loss. Or it could be due to severe diarrhea, severe vomiting, or insufficient intake, or not enough intake or fluids. All these factors can lead to 2 types of shock: hemorrhagic shock and hypovolemic shock. Secondly, if you have a pump failure, what causes pump failure here? It leads to a flare in the heart. Thirdly, a flare occurs in the arterial side. How does a flare occur in the arterial side? A flare occurs in the arterial side due to refractory vasoconstriction. Why? This is also so you can understand it and really grasp the concept. It is absolutely essential that there be a consistent and independent level of arterial tone to maintain adequate tissue perfusion throughout the body. Otherwise, if tissue perfusion is compromised, there will inevitably be a state of severe tissue hypoperfusion. Therefore, maintaining this specific perfusion tone is extremely important for the body's health, ensuring that all biological systems receive the necessary blood flow to function correctly. And if this tissue hypoperfusion occurs, there will be tissue hypoperfusion, and this is called the distributive shock. After that, if you look at the diagram, you'll find that there's a type of shock you can identify from the diagram. The first is the venous side, which we mentioned as hemorrhagic and hypovolemic, then the heart, pump failure, then the artery. Loss of peripheral vascular resistance. There is another type between the heart and the artery. The heart might be working well, but there could be a problem in the middle of the arterial side. This problem is called obstruction. To understand obstruction, you need to know that there are 2 types. One type is called physiological obstruction, and the other is called anatomical obstruction. Anatomical means that there is a problem between the heart and the aorta. It could be aortic stenosis, coarctation of the aorta, or anything else that might cause narrowing or obstruction. The second type is that it could be physiological. If you take a moment to consider the anatomy, you will likely realize that there could be a specific condition called a patent ductus arteriosus, situated between the pulmonary artery and the aorta. And between the pulmonary artery, this duct is very important. After delivery, it is supposed to start closing within hours or at most within a few days. If this duct does not close and remains patent and significant, you will find that the blood flow shifts from the aorta to the pulmonary artery, and there won't be enough blood moving, and this causes a problem, which is the patent ductus arteriosus. After that, there is another type of obstructive anatomical shock, which is when an important activation occurs. For example, tamponade. So it compresses the heart, and the heart cannot pump properly, even though the myocardium itself is fine, or something called pericardial effusion or pneumopericardium occurs. Any decrease prevents the heart from pumping this blood to the arteries. All these things are called obstructive shock, which is another type of shock. If you look at this image, you will find that there is another type of shock called multifactorial shock. That is, there is more than one type together, such as sepsis, septic shock. Septic shock often involves organs, usually gram-negative bacteria. Negative bacteria produce toxins. These toxins go to the heart and cause myocardial depression, leading to heart failure, which is cardiogenic shock. They also affect peripheral vascular resistance. It causes a flare and leads to distributive shock. There is a second type of multifactorial shock where all three are present, meaning there is a flare on the venous side, a difference in the heart and in the arteries. And this is common because the neck contains organs and does the same thing as in septic shock. A pump flare or heart flare occurs, causing a flare in the heart's temperature, but something else also happens called a compromised area. In this compromised area, fluid leaks out of the vessels and goes into the interstitium, resulting in something like fluid loss. However, the fluid loss does not happen on the body side, it happens on the tissue side, which is why edema occurs. And hypovolemia also occurs in the exposed area, which can cause 3 types of shock, or it can cause 2 types of shock. But after that, there is only preload, as we mentioned, hemorrhagic and hypovolemic, and heart, which are heart failure, pump failure, and distributive. One of these shocks is anaphylactic shock. Because if you understand the names or the mechanism that occurs, you will be able to understand where anaphylactic shock is found. In the peripheral vascular resistance, there is a sudden failure due to anaphylaxis or distributive shock, whether it's anaphylactic or neurogenic. It's the same thing. So you understand neurogenic, anaphylactic, or septic shock. When you say septic, you must understand that it will be distributive in nature, and there will likely be heart failure due to the specific toxins that cause significant depression in the patient. These were the primary types, the classification, and the underlying etiology of shock. Now, let's move on to the diagnosis. I want to remind you that when we talk about shock in our specific way, we are not going to go into all the minute details, colors, and nuances, although all these things are very important and nice, and you'll find them everywhere in the literature, But we choose certain specific points in everything, and I'll tell you about them in detail. But I want to remind you that the main goal of talking about shock is not all the things we've discussed or will discuss today. The goal in the end is to tell you that we haven't even started talking about the core of shock yet. Everything we've said so far and everything we will say in the future is just management, nothing more than that. But what we really want to say essentially is about the clinical experiments. The experiments are the primary reason we started talking about shock. They brought us here to this point. But we have to give some thorough introduction, so we pick out important things from it. In the diagnosis phase, it's extremely important to be able to recognize, of course, we will read the classic diagnosis of shock, but I want to tell you something very specific about hypotension, about the nature of hypotension. If the system fails you now, and imagine you go and say, honestly, I have a patient whose blood pressure is 100, blood pressure is 32. What's the issue? What should I do? You will check whether this has become normal or abnormal. How do I know if it's normal now? Could it be good? Could it be not good? I know where, let's not make it too long. The blood pressure, so you know if it's normal or abnormal. Wherever you are, you should refer back to tables and graphs. They're available online and everywhere. You can keep a reference with you and check it. You categorize the patient according to gestational age and also by age after delivery, that is how many days, since there are graphs for that. They even divide it by hours, like 12 hours, 24 hours, day 2, 3, 5, whatever it may be. And then for gestational age, they would start from 24 weeks and so on up to term, so they can tell you about that patient. If you know how many weeks and how old they are, you can see the systolic and diastolic values and who follows them. Are they normal or abnormal? This is the proper scientific method that exists. But there is something called rough estimation. Rough, meaning quickly, because when someone calls you and says she delivered, you can tell her, all right, let's check, or you can open a reference and look it up, no problem. But at least you should have an initial idea. The impression or the rough estimation says that the gestational age should have a mean similar to the gestational age, or at least not less than the gestational age. For example, if I tell you 32, the mean black bridge, and you ask the patient how many weeks, and she says 30 weeks, you would say that's good. 30 weeks and the mean is 32. So this is very reasonable, so we don't worry. Also, go and look at the reference. It will show you how well it matches. But if I tell you the patient is 36 weeks, you'll find that you're running into a problem in the level. The level is supposed to be lower, for example, but after that, you need to determine what the expected level should be. And you will also need to carefully identify and establish the expected level, age, or the reference level, that maintains a standardized acceptable range of values for every specific individual level being analyzed. It must be emphasized that the expected level should be exceptionally robust and clear. It should be strong. And the expected level should not merely be defined by the presence of hypotension. The patient could be in a state of shock and still be physiologically compensating, and this is something that is critically important. This is a concept that is especially emphasized by those medical professionals who work in hemodynamics, specifically in the field of pediatric hemodynamics, who frequently manage complex cases of circulatory shock. Why? Because it is very important to detect shock before hypotension occurs, since the patient may still be compensating independently. There is a significant clinical advantage to consider. The patient can effectively maintain their systemic blood pressure while still being in a state of shock, because the physiological state of shock is not solely defined by comparing it to hypotension alone. Shock is a major factor in diagnosis. If you read about it, you will find oliguria, anuria, and poor capillary perfusion. So I don't want to get into patient capnography and tachycardia, just read about it, but the discussion is very different. There's no need to waste time on it now, but I want to emphasize something about blood pressure. Don't wait to start addressing problems until you see sudden complications. Because when someone tells you that patients are at high risk for sudden complications, it doesn't mean it's impossible. It means you need to assess and see if they have other types of issues or not. And if you find them, you should start addressing them. Why? Because this makes a huge difference in the field of data development, in the field of development that is our schools. All the schools' curricula are in the field of development. But when you intervene or call for treatment, you need to be focused on the outcome. Otherwise, you might treat something and the outcome turns out to be very important. To be good at outcomes, you need to start interventions before hypotension appears on the patient, whether in diagnosis or in investigation. I want to tell you two brief things. First and foremost, whether you are currently dealing with patients or not, you need to be equal to something very important, which is the practice of echocardiography. You absolutely need to perform a comprehensive echo because you want to make a single accurate update for the management of shock. I'll tell you, echo is the first thing, the second thing is echo, and the third thing is echo. You must do an echo. We know that echo is an essential part of shock management. You can't manage shock without echo. Let's continue. We know that there are two types of echo, anatomical and physiological. How is that? Anatomical means you see a part of the heart. That's what cardiologists do. They look at a part of the heart in the heart station, or in the heart unit, or in the heart department. All of that is anatomical. But there is also functional echo, which is done by people specialized in hemodynamics or by cardiologists who know how to perform functional echo. This is precisely what specialized neonatologists do in their daily practice. They meticulously assess the complex function of the heart itself, rather than focusing on the general function of the surrounding area. This distinction is incredibly important for patient care. We truly need to understand that the comprehensive assessment of the heart in these vulnerable patients is strictly based on actual heart function and performance, not merely on the function of the localized area or surrounding tissues. So we need to recognize two things. Secondly, we need to know that the assessment of patients is based on the function of the area. NIR stands for near infrared spectroscopy. If you look it up in any topic or read about shock anywhere, you'll find something called NIRs. We want to understand what NIRs is so we don't just memorize it. I'll tell you a nice story so you can understand. In 1980, a very important breakthrough happened in physics. You know that physics is very important and is involved in everything. Physics is extremely important, and of course you've seen in the respiratory support that it's all about physics. Let's not drag on. There was a major discovery in physics during that period. That was the laser. They started producing laser, meaning radiation or light at a specific wavelength that can perform a certain function. What was the idea behind it? The idea was to generate light at a specific wavelength that could detect something when it happens to it. Detection triggers a reaction. That's the sensor. They developed sensors from this concept. Knowing which doors you open, a car approaching to generate a report, all of this and more. All the sensors that have changed came from the idea of lasers or radiation that comes from physics. In other words, they changed the whole world, just so you understand the importance of physics. And as we will say, there is something called a sensor, and this is the flow sensor and the pressure sensor. We used it in the air. Here they used a very nice person. He said, I will create a signal or a laser that interacts with what? With hem, or what is hem, or beyond hem. And when the hem responds, it can tell us that this area contains hem. And where is this hem found? In iron. And where is iron found? In hemoglobin. So where is it found in hemoglobin? In the red blood cells. And what is found in the red blood cells? In the cells, to put it simply, if I have this laser, and it told me that if there is hem, then there are cells. So it is present throughout the whole body, not just in the cells. If I do this, I can see whether there is blood or not. What does this mean? It means that there is perfusion, and at the same time, the shock report is that it resembles perfusion if I place this probe on an area. And if I say there is blood, then there is good perfusion. And if there is no blood, then there is good perfusion, meaning that there is perfusion. I can assess shock. I can place it on the hand. And if the patient has a deficiency, you can place it on the heart, or on the kidney, or on the liver. Any organ, I can observe perfusion in it. The lowest on the table is the nerves, and the person who invented this topic and discovered the principle in 1908, there was a man named Ferrari. Ferrari is a famous name, so we remember it. Later on, it was used in the city about 15 years ago because it was a new engine, and even now people don't fully understand it. But there are some who use it and get good results from it. Let's go back to the medical treatment options. And when it comes to the treatment, there will be two measurements. I call them the sacred tables. First, you know you have it. Two tables, a table for the receptor and a table for the medicine.